hallway medicine, substandard care, growing wait times, and increased infection rates. Those are just some of the difficulties generated by hospital overcrowding in Ontario, as facilities in the province are sometimes running at up to 140% of capacity. How can our healthcare system do better? Let's ask Jeanette Despati. She is President and CEO of Cornwall Community Hospital. Dr. Howard Ovens, Chief Medical Strategy Officer for the Sinai Health System and the Provincial Lead for Emergency Room Medicine. Anthony Dale, President, CEO of the Ontario Hospital Association. And Candice Chartier, CEO of the Ontario Long-Term Care Association. And let me first just say, as we often do on this program when we talk healthcare and politics, in the interest of full disclosure, my wife is an unpaid volunteer helping the Progressive Conservative Party of Ontario with health policy, so we put that out there for everybody's edification. Great to have all of you around our table tonight for an important discussion, and I will start with reading this. This is an excerpt from an interview with an ER doctor as published on the website healthydebate.ca. Here we go. I cared for a girl who likely had appendicitis, but there was no bed to examine her in. So I found a jerry chair in the hall and put her in that. We had just let someone with kidney stones who was in that chair go. We were so crowded that we had run out of IV pulls. The nurse had taped the IV bag for the previous patient to the wall. When he left, no one stopped the IV, so there was a puddle of water on the floor. Her mom asked if I could examine her in a private area. I said I would like to, but I just didn't have the beds. I said I wouldn't lift her shirt, so I did a subpar exam. That's one example, as told to Professor Andreas Lapakis from U of T. And Anthony, I want to start with you, since you're the guy who represents all of the hospitals across this province. How common is that?
Well, there's a lot of passion wrapped up in the story you told and the whole story when you read it online. And I think it's really the conditions that are leading to that kind of commentary and concern amongst clinicians, nursing leadership, and other healthcare professionals that's increasingly complex and challenging for the hospital sector. You know, about 18 months ago, I started to hear from hospital leaders from right across the province concerned about crowding and congestion in hospitals.
How long ago was that?
About 18 months.
18 months, okay.
And something has happened in that 18-month period where hospitals that used to have a little bit of give, I mean, it's a very busy place, a hospital, but there's usually a little bit of give to deal with the unexpected, to deal with flu surges and so on. But something was really different. And last winter, when the flu arrived, as it does every year, it really exposed a very fragile underpinning within the hospital sector, a sector that is now, in our opinion, at the outer limits of its ability to deal with increasing patient demand and the conditions that it clearly is facing today.
Well, you've got a hospital CEO sitting right beside you, so I want to ask you, Jeanette, if the description I read off the top and the scenario just described by Anthony is something that you see at your hospital.
Well, I'm sorry to say it is. I think that what you've described could be a description of an emergency department in many of our hospitals across the province, but certainly could happen in Cornwall because we know that increasingly we're trying to care for patients when we're in an overcapacity situation.
He's got an 18-month timeline on this, saying it's gotten particularly worse in the last year and a half. Have you noticed that as well?
I would agree, and what we see is that it is not sporadic. It really continues. We know, for example, for the entire year, 16-17, our average occupancy was 116%. Some days it was as high as 130 or 135.
We need to just pause and understand that, because obviously one assumes that 100% is complete capacity. How do you have a hospital at 140% capacity?
Exactly. So, good question, but those are the patients that remain in the emergency department. They're admitted. That, unfortunately, is when we move to hallway medicine. Patients are cared for in the hallways of inpatient units and the hallway of the emergency department.
Which is, I guess, as they say, suboptimal.
Well, I would suggest that it is, given the impact that hallway medicine has on our ability to provide good quality care and to address patient safety the way we'd like to.
Howard Ovens, I guess I need to ask you, what's been happening in the last 18 months that has changed things from sort of occasional overcapacity in the past to an overcapacity crisis right now.
So let me back up before I answer that and just address the anecdote that you described. Hallway medicine is an everyday experience for patients and staff in our emergency departments. I will never defend hallway medicine. It's not good medicine. It's not good patient experience. It is a compromise on dignity and privacy. It could be worse. The patient could be sitting in the waiting room just waiting to be seen without being seen in a hallway. And so at least the fact that we are proactively dealing with our waits by bringing people into non-traditional areas and getting them assessed and taking responsibility for them is better than some of the historical experiences I had in emergency departments in Ontario and Toronto in the 90s and early 2000s. Things got quite a bit better after we brought in a provincial overcrowding strategy in 2008, and probably slowly we're improving beyond that until, again, about 18 months ago.
What happened?
I think the cumulative effect of 5 or 6 years of funding restraint on our hospitals and several percent of cuts each year were absorbed, and just we started to hit a wall and we couldn't absorb them anymore. And actually, probably last flu season, the data looked a little worse than this winter. We did have a surge strategy in the fall by the province that took a little steam off an overheated radiator. But the trend line for the last 18 months has been very concerning, and I think it relates to underlying hospital budgets being cut to the bone.
Let me do a quick follow-up here, because I've kind of seen this play before, which is usually what happens. The province sets a budget for hospitals. The hospitals say it's not enough. The provinces say that's what you've got. Flu season comes and a bunch of doctors have a press conference saying, if we don't get more, this place is going to hell in a handcart. The government then ponies up some more, and the story tends to die down for a while. Did that not happen this year?
I think the story is a little more nuanced than that. Are
you saying I'm not nuanced, Dr. Ovni?
Never. This is a deep dive compared to most of your other media competitors. So I appreciate the chance to talk about it in depth. But we have a wealth of data that compares us not just historically to ourselves, but to other jurisdictions. And we know that our acute care bed capacity for our size of population is very, very low. At the low end for Ontario, it's at the low end for Canada. Canada's at the low end for developed Western nations. Usually we run in the bottom 2 or 3 out of 32 countries in the OECD grouping who compare stats. So we absolutely are a very efficient hospital and healthcare system when you look at how we provide care for the number of beds we have. But there's very little resilience built into that model, and flu season exposes it, and several years of budget cutbacks have created a great culture shift as a tax-paying citizen. I think funding reform and the way we do funding for hospitals is a step in the right direction, but the absolute amount of money being invested has been, like I say, taken us to and beyond a limit.
Okay, just stand by 1 second, Anthony, because I want to. You're hospital, not a hospital, and you have a different piece in all of this, which is why we wanted you here today.
Right.
If your long-term care sector were better able to handle some of the problems that currently are in hospitals, blocking beds for more acute cases, would this problem go away?
I don't think it would go away with just hospital and long-term care. I think community plays a huge factor in this. You look at our sector, we care for over 100,000 residents each year. We have 30,000 more beds coming into the system.
Over what period of time?
Over the next decade, 5,000 over the next 5 years, basically. But we also need to look at what is happening in community. I think you talk about the 18-month window. If you look at long-term care, where 3 years ago our residents were staying with us for an average length of stay of 2.5 years, it's down to 12 months right now. So what's happening is the community's trying to care for them. It's harder to get into long-term care. So people are staying in the community, which is good, but if there's enough community resources, it's not good. And then what's happening is I think people go to the hospital because they think that's where I need to go. I'm sick, I need to go to the hospital. So I don't think that it's one part of healthcare. I think it's a cumulative issue that we have to put it patient first. We have to have a seamless path, and we don't have that seamless path yet.
Gotcha. Anthony, you wanted to say?
Yeah, I wanted to build on what Howard and Candace said. In 2008, when the province had its financial meltdown and the Great Recession happened, the hospital sector was asked to do everything it could to control costs and absorb inflationary pressures. It's been a huge part of the solution for over a decade, and the data shows some of the most efficient metrics you can find in the country when it comes to hospital performance. There's been also in the hospital community a strong consensus that the solution for care lies in building capacity in long-term care and in the home and community care sector. And it's that promise that has kept everyone's eye on the ball for so long. But as Howard says, the sector is really at its outer limits of what it can do in terms of major gains in further efficiency. The solution lies in building significant amount of new capacity in the long-term care sector, of course, also in the home and community care sector, absolutely, they're part of the solution.
That takes time, though, Anthony.
It sure does, which is why we need a bridge strategy, because our hospitals are now facing essentially unprecedented pressures.
Well, the province thought it had that bridge strategy, right? They announced they're going to reopen some formerly closed hospitals. Does that go some distance to helping this?
I agree with Howard. It has certainly helped provide a cushion for this winter. Those beds are for this fiscal year only, and the truth is, as we stare into next year, to the fiscal year coming up for 18-19, the sector is facing an unprecedented degree of uncertainty. It doesn't have any real clarity, not just hospitals, but other parts of the continuum about what it can expect from a budget and a financial point of view. And that's a challenge given the circumstances we're facing today.
Well, you've, again, got the big picture. I want to go for the now deep dive focus on your particular hospital. What's your annual budget?
Our annual budget's about $125 million.
And I presume you asked the province for a top-up in order to get through this particularly challenging time?
We actually were fortunate in that we did receive surge bed capacity.
How much?
For this winter. We received an extra 20 beds, which is great. I will tell you this morning, we had 20 people in emergency waiting for admission. So that was above the 20 surge that we have open.
So even though you've got 20 more beds, they got snapped up like that.
That's right.
And you've still got people now waiting on top of the 20.
That's right. Now, we are in one of the worst weeks that we've had this winter currently. Mm-hmm. But certainly, and the bigger question, I know Anthony alluded to it, is what do we do in April when we don't have any assurances at this point anyway that surge capacity will continue into next year.
The surge capacity is expected to expire when?
At the end of March.
End of March. So
Yes.
Then we're into a new fiscal year, April 1st.
Exactly.
And you've got to have more conversations with the health minister, I guess.
Absolutely.
And,
I think that's a provincial conversation. I don't think it's unique to Cornwall, but certainly we will be involved in that conversation.
Maybe just help the nerd in me here. How does this work exactly? Do you negotiate with the province and get a global figure, and then you divvy it up to the hospitals, or do they negotiate directly, or how does it work?
Yeah, at the moment, we're on a really short-term planning cycle. It seems as though everything kind of hinges on 6-month periods of time. You work toward the provincial budget, and then you work toward the fall economic statement, because the province's finances are so tight, and there's other considerations. And from our point of view, that's on the verge of becoming dysfunctional for a hospital sector of this size and a health system of this size. And we have to get on a more mature, long-term planning horizon. And that's really where, again, the wonk in you may be interested in this. Capacity planning is so important. We have to stop thinking in such short intervals and from year to year, and we have to start thinking about the long term. What do we really need in terms of hospital capacity over the long term? equally as important, what do we need in terms of home and community care capacity over the long term? What do we need for long-term care over the long term? Assisted living, and of course the social services that are so important to keeping people out of hospital. We're caught in a period right now where we can't seem to get out of that short-term horizon, and it is the cause of the congestion today.
Howard Ovens, what is the reason why we're caught in that short-term horizon as opposed to much longer planning?
Well, I think we're kind of addicted to shorter and shorter sound bites, news cycles, and the politicians follow suit. And there isn't a lot of reward for long-term planning and seeing a strategy through. So in some respects, we're our own worst enemy publicly, in that we get the government we deserve. And it seems like really committing yourselves to a long-term strategy is very difficult thing to really pull through.
But here, humor me for a second here. Here's the reality, which is there's going to be an election in 4.5 months.
Yeah.
Now, if the current Minister of Health said, you know what, I'm going to give your hospital twice as much money next year as this year, there's every possibility he won't be the Minister of Health in 4.5 months. You know, might lose the election, he might get shuffled to another portfolio. The realities of politics are such that you can't make a 5-year commitment to a hospital, can you? If you're in government.
Well, the commitment can be changed. That's the nature of any contract with government, is that the same government or a new government can change the commitment as circumstances change.
So how do you get long-term
predictability?
predictability?
I think it takes leadership and vision, and it takes also, to some extent, a media and a public that respond to those types of messages.
It's important to remember that this is not a debate about only the funding of different kinds of providers. There's people, patients, clients that are at the heart of this. Right now, we have more than 4,500 patients sitting in hospital. They're often frail elderly. They often have chronic long-term conditions, and they keep coming back. And sometimes it's increasingly common that they can't be discharged because there's no other place for them to go. That's 4,500 people with families, with personal lives and histories, and I think we're forgetting that they're at the very heart of this. That number has increased by 20% in just a very short period of time. So every day that goes on that we're not getting serious about a long-term plan, the number of alternate level of care patients is increasing.
So let's just understand this. In a hospital, that is the most expensive setting for those patients to be cared for. If they could be in one of Candace's long-term care facilities, which is a cheaper model for addressing their needs.
It's also arguably a
and better,
more appropriate level
and more
of care.
appropriate.
Yeah.
So
We'd save money and do better.
Yeah, we've done a lot of work in modeling around different models of care. I think the reality is we can't just keep these siloed sectors happening. We need transitional models of care, and it's something we've done a lot of work in Long-Term Care Plus. And it's other models of care, so that take a post-acute model. So you fracture your hip, you're in an accident, you go into the Cornwall Hospital, you get that hip repaired, and then you're out of there. You're rehabbing in an appropriate setting at less cost and freeing up that acute care bed for the people that really need it.
But does that alternative setting exist yet?
Well, it does to some degree, and this is, in the budget this year, it was announced, the potential models of care, and it's still being worked out, but voucher systems, looking at, I have 34,000 people on a wait list to get into a long-term care home. Maybe some of those could be cared for elsewhere. We've got an opportunity over the next 3 years even of using decanted long-term care homes that can't be redeveloped and using those for other care sites. I know there's rehab happening in one site. I know retirement homes are looking at turning their wings into other model of care. So it's happening. It's just we have to get it moving faster.
Jeanette, you wanted to say.
I did. I just wanted to comment on those patients that are waiting for long-term care and sitting in acute care spaces. No, Anthony alluded to it, but those are not the patients that we're serving well. We're not meeting their needs. They really do need to be in community or long-term care settings. We're an acute care environment.
Just explain the distinction between the two.
So we're providing meant to provide intensive acute services. So a long-term care patient that's sitting in our hospital probably needs more rehab than we're providing. They need more stimulation. They may have dementia issues, which are only exaggerated while in our environment. So we're not doing these folks a favor.
Howard, I have to tell you, I've heard this story many, many times, and everybody seems to know where we need to get to, but getting there and getting there quickly enough just seems to be beyond the capacity of decision makers nowadays. So what do we do about this?
Well, I think first of all, I do think we've made some progress in some areas. I think that I alluded to the last 10 or 11 years where we've had some incentive programs for hospitals to improve emergency access and reduce wait times, which really has helped us get through the last 18 months safely without some of the kinds of inquests and tragedies that we experienced in the 90s during a period of cutbacks. I alluded to some of the good cultural changes and operational changes brought on by health system funding reform. The issue of bundled care packages to help break down silos produces some promise.
What does that mean?
So rather than just paying the hospital separately, the rehab facility separately, the family, physician, and community care access people separately, there would be a bundle of money. Somebody would have to be the fund holder, and you would take care of the patient anywhere in any of those locations where they needed it most, without there being a financial disincentive to move people. And some of our hospitals are creating partnerships, like Sinai Health System is the one I'm familiar with. That's where I work. We can move people directly from our Emerge now to Bridgepoint Active Health Center, which is part of our system. And
it's another hospital, maybe 15 minutes away from Mount Sinai downtown.
Traffic on Girard can be a little less or a little more than 15 minutes, but it's quite close. Yeah. And we've made it as really quite seamless. And we've had people come in the morning to my Emerge and be over at Bridgepoint for rehab and reactivation care the same day. The experience we were talking about, why people who are alternate level of care are not being well served. Ideally, if you're in for a longer stay, whether it's rehab or long-term care, it should be a more home-like setting, as well as the additional services. But a hospital,
it's not home-like.
It's not home-like. You can get a TV and you can put some flowers beside the bed, but it's never going to feel like home. And ideally, some of the post-acute care options can feel more home-like. So we're actually pretty good at innovation in Ontario and Canada, but we're not very good at rapidly scaling up some of these positive innovations and getting them scaled up and broadly.
Jeanette, I wanted to ask you, if somebody gets sick in your neck of the province, Cornwall, Ontario, what expectations should they have that if they need to go to your hospital, they can get the care that they need?
Well, I am confident to say that patients coming to the hospital do get the care they need.
Even at 140% capacity?
Yeah, I think that our providers have, and direct care frontline providers have done what they need to do. I often say to the board, we'll get complaints about wait times in the emergency department, and we'll get complaints about patients that are being cared for in the hallway. But what we don't hear are from those patients and families that are real trauma cases. We're ready for that. However, having said that, I will say that when I'm asked by the board, what keeps you up at night as a CEO, my typical response is that huge accident on the 401.
I was just going to say, you guys are right on the 401, and if there's a 20-car pileup on a foggy day, all your projections are out the window, aren't they?
A large volume of critical cases would be a challenge, no question about it, and I think it's one of the risks of the way in which we're managing today. I'm sure Cornwall's not unique. Of course, we have all kinds of strategies and emergency planning situations, but we don't plan for 130% capacity at the same time.
Okay, Anthony, you ready for my smart aleck question here?
Sure.
I'm going to play devil's advocate with you. Again, I've seen this movie before where, it is in some respects in the interest of the Ontario Hospital Association to say, things are terrible out there. We got to have more money. If we don't have more money, people are going to go starving in the streets and they're going to, okay, we get that. How do we know, because we don't know the system, how do we know that the needs that you are describing today are genuine, foundational to the hospitals of this province and not just an attempt by hospitals to exploit a situation in order to get more money?
There are 23 million patient visits a year in Ontario hospitals. And if you ask that question, I invite you to visit really the emergency department in any community hospital or academic healthcare center or even small community hospital. They are heaving under enormous pressure right now. All the data and evidence shows a hospital sector in Ontario that is the most efficient in the country. Length of stay, per capita expenditures, beds per capita, you name it, Ontario is the most efficient. You've talked a lot about the continuum, the other parts of the healthcare system needing more time to build up capacity, and we agree. That's why we're recommending a bridge strategy for the upcoming budget. We've recommended an investment of 4.55% in Ontario hospitals as a way to maintain existing capacity and also account for some growth in costs that we can expect next year.
What dollar figure does that represent?
It represents approximately $1 billion. But we think it's a worthwhile investment in patient care, especially after almost a decade of austerity.
Well, here's what government people tell me. They say we could double the healthcare budget tomorrow. It wouldn't make Ontarians twice as healthy.
What I guess I would say to that is the year ahead is unlike many other years because of the amount of efficiency gains that have been made. And the sector I work with most closely, hospitals, are telling me that there's some serious trade-off decisions ahead. And that's a trade-off decision that nobody who works in healthcare ever wants to face because they're devoted to the delivery of care, they're devoted to caring for people, for patients and clients. But this year ahead is different. And that's why our recommendation is so significant. We appreciate that, but it is an investment in maintaining access to care.
You've made that ask to the Minister of Finance?
We have a meeting with Minister Sousa in a couple of weeks. We've obviously met with Minister Hoskins. We were in a forum on Friday with the Premier, actually, and so there's a lot of healthy discussion about this right now. The government has shown over the last 2 years that it's willing to return to some reinvestment in hospital services, especially given the data and evidence. And so we're hopeful that our recommendations will be well received on Budget Day.
Okay. Again, Candace, I want to come back to you because I think we need a better understanding of your part in how this all works out. If someone needed a long-term care bed right now in this province, how long would they have to wait for it if they put their name on a list today?
Totally depends where you are across the province. The issue with long-term care is you have classified homes. So you have A homes, which are new homes that meet new design standards. And then you have B and C homes and sometimes upgraded D that you have four bed wards. So do you want your grandma or grandpa to live with 3 other people in a room and the odds are 3 out of 4 have dementia? It's not attractive.
It's not optimal, but it might be better than staying in a hospital.
Yeah, and there's respite beds across the province, but it really depends on where you are in the province. We're in 634 communities, so we have a very broad footprint, and it also depends on your relationship with the community care and the hospital. Like, what does that region look like?
Well, is it a given to say that if you're in a big city, the wait's going to be shorter, and if you're in rural or northern Ontario, it's going to be longer?
Yes and no. There's more access to services in Toronto, but we also have an issue in Toronto where we don't know how we're going to redevelop some of the homes in the city, and so that's a strategy that we're actually asking government to sit down and figure out what we can do.
Okay, I'm keeping a list here. Hang on one second, Jen. I'll get right to you. OHA wants $1 billion for their 4.55% bump up for this one-time only bridge situation. What do the long-term care association homes need?
I hate to say it, but we have fared very well, I think, when it comes to more predictability, and like we're getting multi-year budgets. We just found out we're getting 15 million hours, we're getting 30,000 beds. I mean, a lot of what we asked for in the fall, we're getting. And I think it's because of the demographics, and people see through capacity planning that 20 years from now, 1 in 4 people in this province are going to be a senior over the age.
Over 65.
Yeah, and that's really hard. And when you look at, you got to start building now. We're already having surge issues and capacity issues. So it takes, I'm going to say, an average of 3 years. Some operators say shorter, some operators say longer, from shovel in the ground to first admission. So, and we're running out of time. So there's a lot of projects in the queue right now, and there's going to be a lot of building, but we still have to get the relationship between all of us at health to say, okay, so what are you going to do? What are we going to do? What's community going to do in order to make this seamless?
You know what, though, Candace? I do not mean this to sound cynical. No one in 4.5 months' time is going to get reelected because of what they're promising to do 25 years down the road.
Yep.
Right?
Right.
So,
And therein lies the conundrum statement.
right.
I was talking last week to the CEO of a very large hospital in Eastern Ontario, who reported to me that over 6 years, out of the budget of the organization he leads, $160 million has been taken out in efficiencies while maintaining access to care. So on the question of the appropriateness of an investment of this magnitude, there are examples like that to scale all across the province, and it's illogical to think that you can keep demanding that the hospital sector absorb that much inflationary pressure and operating pressure and not at the same time expand capacity across the continuum, and there not be the situation that exists today with such a high degree of congestion and overcrowding.
So what do we do about when political reality meets up with long-term need? How does one resolve that conundrum?
Well, you listen to data, you listen to evidence, you get out into emergency departments, you visit long-term care homes, you see for yourself the circumstances that the sector is facing, and then you overcome some of the short-term considerations that may seem important, because frankly this is incredibly important. And I just take it right back to the patients and the clients who are depending on this healthcare system.
You
Howard?
innovate.
Yep.
You need to innovate and get innovation and new models of care and transitional models of care.
I'm sorry to keep bringing it back to politics, but we are in this, I mean, 'tis the season. And the fact is, Howard, the province of Ontario, the Liberal Party, cannot go to the people for re-election with a budget that's not in balance, right? They have to have a balanced budget. That will be one of their calling cards. And if the hospitals of this province want $1 billion more next year than they got this year, how does the province of Ontario do both of those things at the same time?
So I'm not an expert on that, but I'll tell you what gives me nightmares, which you asked a few minutes ago. From my role in this whole system, the thing that gives me nightmares is our most vulnerable people are the patients who almost no hospital today can do everything for everybody who comes through their emergency department doors, whether you're Cornwall or Sunnybrook or St. Mike's, it doesn't matter. And so we need to be able to move people who walk into or get rolled into Emerge A to definitive care, and often within 4 hours if it's a life or limb threatening problem. We've worked very hard and improved the system for moving those kinds of people who are our most vulnerable patients, most acutely in need. But actually in the last couple of weeks, we've had occasions where some of our lead hospitals have actually had to defer life or limb cases. They've said, we cannot take a life-threatening emergency for the next 12 hours. We're stretched too thin. I don't, since we put this system in place, I don't recall that ever happening. And no hospital would responsibly do that if they had any other option. So, from my
politics and policy collide.
yeah.
Indeed. I hope you guys figured this all out, because we need you to figure it all out. So best of luck to everybody, and thanks for coming in tonight to TVO and discussing it. Anthony Dale, who's the President and CEO of the Ontario Hospital Association. Jeanette Despatie, half the family pronounces it Despatie, President, CEO of the Cornwall Community Hospital. On the other side of the table, Candice Chartier, CEO of the Ontario Long-Term Care Association, Dr. Howard Ovens, Chief Medical Strategy Officer for the Sinai Health System and the Provincial Lead for Emergency Room Medicine. Thanks so much, everybody.
Thank you.
Thank you.
The Agenda with Steve Bacon is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.